Hello everybody, now we will read about preeclampsia. Preeclampsia is a pregnancy-specific hypertensive disorder with multisystem involvement. Now, criteria for preeclampsia. Preeclampsia is gestational hypertension accompanied by more than one of the following new onset conditions at or after 20 weeks of gestation. Now, the criteria are: first, proteinuria; second, other maternal organ dysfunction including AKI, where creatinine is more than 1 mg per dl, liver involvement, elevated transaminases, ALT or AST more than 40 international unit per liter, with or without right upper quadrant or epigastric abdominal pain. Third, neurological complications. Examples include eclampsia, altered mental status, blindness, stroke, clonus, severe headache, persistent visual scotoma. Hematological complications, where platelet count will be 1.5 lakhs per microliter, DIC and hemolysis. Third, uteroplacental dysfunction such as fetal growth restriction, abnormal umbilical artery Doppler or stillbirth. Now, pathogenesis of preeclampsia. First, several mechanisms of disease have been pre-posted in preeclampsia. First, chronic uteroplacental ischemia. Second, immune maladaptation. Third, very low density lipoprotein toxicity. Fourth, genetic imprinting. Fifth, increased trophoblast apoptosis or necrosis. Sixth, an exaggerated maternal inflammatory responses to deported trophoblasts. Now, vascular changes. First, lack of hypervolemia causes hemoconcentration. Second, interaction between potent vasoconstrictors, that is thromboxane A2 or endothelins, and vasodilators, prostacyclins and nitric oxide, causes intense vasospasm. Third, frequent capillary leak and decreased colloid oncotic pressure causes elevation of pulmonary capillary waste pressure and increased risk of pulmonary edema after aggressive fluid therapy. Now, hematological changes. First, increased platelet activation, aggregation and consumption causes thrombocytopenia. It is a marker of disease severity. Second, high hematocrit due to lack of hypovolemia. Third, high serum concentrations of lactate dehydrogenase, that is more than 600 international unit per liter, may be a sign of hemolysis. Now, hepatic changes. First, periportal necrosis causes increased transaminases. Second, hepatic dysfunction causes increased lactate dehydrogenase. Third, significant hemolysis causes increased bilirubin. And fourth, significant liver dysfunction or suspected placental abruption causes disarranged coagulation profile. Here, platelet count will be less than 1.5 lakhs, precedes abnormal coagulation profile. Now, renal changes. First, tubular permeability to most large molecular weight protein causes non-selective proteinuria. Second, increased tubular reabsorption of calcium causes decreased urinary calcium. Third, vasospasm. It causes contraction of intravascular spaces that leads to worsening renal sodium and water retention. Fourth, severe preeclampsia causes intrarenal vasospasm that leads to 25% decrease in GFR and causes oliguria. And fifth, increased reabsorption and decreased excretion of uric acid in the proximal renal tubules causes increased uric acid. Now, fetal consequences. First, abnormalities in the placental bed plus failure of physiologic transformation of the spiral arteries in the first or early second trimester causes decreased blood flow to the uteroplacental unit. Second, placental vascular insults causes chronic uteroplacental ischemia. Third, chronic uteroplacental ischemia causes fetal growth restriction, oligohydramnios, placental abruption and non-reassuring fetal status. And fourth, this leads to an increased risk of spontaneous or indicated preterm delivery. Thank you for listening. Thank you.